Hi, my name is Bruce Strober. I'm clinical professor of dermatology at Yale University, and I practice dermatology at Central Connecticut Dermatology in Cromwell, Connecticut. Psoriasis and psoriatic arthritis often go hand in hand. The prevalence of psoriatic arthritis increases with disease duration and has an estimated prevalence of approximately 1/3 of psoriasis patients. Therefore, you really need to pay attention to this entity. The onset of psoriatic arthritis is often approximately 10 years after the onset of psoriasis, though there are instances where psoriatic arthritis appears prior to psoriasis. That is a much rarer occurrence. It's also important to note that patients with a higher BSA of involvement of psoriasis are much more likely to develop psoriatic arthritis. Importantly, people with psoriatic arthritis have a much more negative quality of life than people who simply have psoriasis without psoriatic arthritis. And this makes it very important for us to screen for the presence of psoriatic arthritis. The current psoriasis treatment paradigm is distilled down into the following approach. Psoriasis patients should be classified as either candidates for topical therapy or candidates for systemic therapy. The latter are patients who meet at least one of the following criteria. Their BSA is more than 10%, or they have disease involving special areas like the scalp, genitals, palmoplantar areas, or the nails. Or they just fail topical therapy outright. And finally, people who have the presence of psoriatic arthritis of a significant nature. A good tool for screening for the presence of psoriatic arthritis is called the PEST questionnaire, or the Psoriasis Epidemiology Screening Tool. The PEST is simple. It involves 5 questions. If 3 out of the 5 questions are answered in the affirmative, there's a very high likelihood the patient has psoriatic arthritis. In fact, it is a 94% sensitive and 78% specific tool. Additional questions I might add, not only including the PEST, are: does the patient have a family history of psoriatic arthritis? Is there morning stiffness after awakening of the joints that lasts more than 15 minutes? Is there joint pain that awakens the patient during sleep? Is there neck pain and stiffness? And finally, is there fatigue? This leads us to the psoriasis treatment paradigm summarized in the following schematic. The patient's BSA being 10% or greater, or disease involving special areas, or the failure of topical therapy, leading to a whole menu of treatment options, such as older systemic agents, phototherapy, or biologic agents. Considering combination therapies can be used. Key points, though, are we have to choose therapies based on individual patient characteristics, and that psoriasis need not be stepwise. In other words, patients need not fail topicals if they present to you very severe, and especially if they present to you with the presence of psoriatic arthritis. If you screen for psoriatic arthritis and find its presence, you'll have to choose a modality that treats both the skin and the joints, because not all the modalities shown on the left part of this slide cover both the skin and the joints. With this approach to psoriasis and psoriatic arthritis, you can mitigate the negative effects this disease entity has on your patients. Thank you very much for your attention.